The August MEC Minute is about seizures and status epilepticus. I don't think we've talked about this for a while. I know we've talked about it as part of the protocol review in the past, but not as a specific topic. So I like to talk about seizures. I like to focus a little attention toward the end on status epilepticus, which is a life-threatening event. And I also like to have a brief discussion regarding use of midazolam versus lorazepam for termination of seizures. Periodically it pops up, and really I think we need to kind of put the question to rest. So we'll talk about that toward the end of the slideshow. So what's a seizure? A seizure is a sudden, brief disruption of the normal functioning of neurons in the brain. Essentially, it's a chemical imbalance. We have some chemicals in our brain that stimulate or encourage and enhance transmission of neurotransmitters. And those, if there's an excess of those transmitters or those substances, then you can have excessive electroactivity. We have other substances that slow down the transmission rate, and by slowing down the transmission rate of these neurotransmitters between nerves, between the synapses of the brain, we can reduce the likelihood of seizure. So a lot of the seizure medicines that we talk about have something to do with either reducing the speed of transmission or increasing the inhibition of transmission of these neurotransmitters. But essentially, a seizure is an electrical short circuit of the brain because of a neurotransmitter issue. Seizure can appear as a sudden event where the patient is awake, alert, and suddenly becomes unresponsive. They may cry out or make some noise before the event occurs. If they're standing or ambulating, they may fall. Typically, we think of a seizure as these convulsive movements of the extremities. There may be interruptions in the breathing cycles, or breathing may be very slow, and there may be cyanosis if the dyspnea or apnea is severe enough, in which case we would want to treat with oxygen. The patient may have a loss of bowel or bladder function. They may bite their lip, they may bite their tongue, they may actually have limb injury. They could dislocate their shoulders or fracture extremities, either because of the direct fall or because of the severe contractions that occur as part of the seizure. And then once the seizure stops, the patient will have a slow return to consciousness, and they may be confused or fatigued after the seizure. I've had patients who have had a grand mal seizure and they've slept for hours afterwards simply because that's part of their recovery phase. And this is what we consider to be a generalized tonic-clonic or grand mal seizure. A seizure can also be changes in the patient's mentation or maybe some focal neurological abnormalities without that grand mal seizure and total loss of consciousness. They can stare off into space. They can do some other repetitive movements such as chewing or pill rubbing or pill movements in their hands, or they can start picking at things. They may be wandering, confused. They may have incoherent speech. They may have episodes of crying or screaming or running or flailing. They may have a sudden loss of muscle tone and they may fall, or they may, again, start picking at their clothes or disrobing. And these episodes can be really difficult to interpret, but these are really considered to be a partial seizure, or known as a complex partial seizure. So it's complex because they have multiple symptoms. It's partial because they are only showing certain bizarre behaviors or may only have certain focal abnormalities, but it's not this loss of consciousness with the grand mal seizure. So possible causes, we have various things that can cause seizures. In children, we're aware of the febrile seizures. The child has a fever, and at about the time of maximum of the fever, or as the fever starts to break, they have a seizure. It's usually brief, it's usually self-limited, and by the time you arrive, the child is awake and back to baseline. There tends to be a family history of seizures. Often the paternal side may have a history of seizures with fever. And having had a fever-related seizure, the child may have another seizure in the future. Seizures can be related to drug use or alcohol withdrawal. Alcohol withdrawal seizures can be life-threatening, so we have to think about, is this patient in withdrawal? And if they are in withdrawal, we need to treat the withdrawal to prevent another seizure. We can have patients who have an hypoxic episode resulting in near drowning, or from a near drowning episode, or from strangulation, or other transient loss of perfusion of the brain. There can be seizures related to metabolic disturbances, so patients who have severe hyponatremia, patients who have severe hypoglycemia, they can have a history of or reported seizures. You may also see seizures related to vasovagal episode. It's seizure-like activity, but it's not epilepsy. Head injuries, head trauma can result in seizures either immediately after the head injury, shortly after the injury, or it could become a cause of recurrent chronic seizures and epilepsy. We always think about things like brain tumors, infections, and stroke causing seizures. We have had patients in years past where they've had a previous stroke. They may have a residual deficit. 6 months later, they present to the emergency department via EMS because they've had a witnessed seizure at home. And it turns out the previous damage to the brain by the stroke becomes a focus of seizure-like activity or electrical short circuit, which then can propagate through the whole brain, causing a grand mal seizure. Patients could have recurrent epileptic seizures, so we'll talk about it on the next slide, but epilepsy is a seizure disorder. It's a chronic neurological disorder. It's where patients have recurrent seizures which may or may not be due to a known source or a known cause. Having had one seizure does not mean you're epileptic. Typically, we diagnose epilepsy with the second seizure, or if the patient has recurrent seizures or has status epilepticus from cause that we can't identify. For us in the emergency department and for you as EMS providers, the most common cause of a seizure is a patient with a known seizure disorder who is either non-compliant with their medications or has had progression of their illness where their medication is no longer capable or adequate to control their seizures. They may need an adjustment in their medication. But for us, really the most common cause of a seizure in the emergency department is non-compliance with a treatment program that usually involves medication. Common cause of seizure is epilepsy. Epilepsy is a seizure disorder. It's a chronic neurological disorder characterized by recurring seizures that are not otherwise provoked by an acute injury or by a health emergency. So causes of epilepsy could include stroke, brain tumor, brain infection. The brain infection could have been treated and is now gone, but now they have focus within the brain that serves as a starting point for the seizure. Patients could have previous head injuries. The patients could have metabolic issues. The patient may have other chronic underlying neurological conditions that can result in seizure activity. And those things could be developmental disabilities, cerebral palsy, or other congenital abnormalities such as a malformation of the brain. There are also certain genetic disorders that can cause seizures and epilepsy, and if they are controlled, then the patient's incidence of seizures can be reduced. But all in all, about 3 million Americans of all ages have epilepsy, so it's a common illness. Again, I mentioned earlier that epilepsy can be a component of cerebral palsy. Cerebral palsy is secondary to anoxic brain injury during birth. So the patient may have epilepsy in addition to their other neurological conditions, whether that's trouble with gait or trouble with paralysis. But cerebral palsy can have epilepsy associated with it. Various cognitive impairments can do it. ADD and ADHD can be sometimes complicated by epilepsy, as well as autism and other developmental disabilities. But the majority of the people who have seizure disorder and epilepsy do not have other impairments and live very normal lives. So their lives are restricted only to the extent that the seizure disorder is disabling. So if somebody has seizures every week, even with optimal management of their medications, they may not be able to work in a safety-sensitive position, or they may not be able to drive an automobile simply because their seizure disorder represents a risk to their safety or the safety of others. But most people have otherwise a normal life. So if we're talking about generalized seizures, those tonic-clonic grand mal seizures, typically the electronics or the electrical disruption involves the entire brain. And the entire brain short circuits. It may start in a particular location of the brain and then spread. These are the patients that lose consciousness. They may fall. They may have stiffening of the limbs, followed by that rhythmic shaking. Their breathing may stop temporarily. They may appear cyanotic. They may have loss of bowel or bladder control. So one of the questions we commonly ask, or almost always ask, is, did you wet your pants? Did you lose bladder control? So it's a good point for you to make, or as part of your interviewing the patient. Typically, grand mal seizures last 1 to 3 minutes. If they last longer than that, then they may still be having seizures by the time you arrive, and they will require medication. Typically, following the episode, they are confused. They may be sleepy or be agitated. We've actually had some of our patients that are agitated and requiring ketamine end up with a final diagnosis of having a seizure. So they've had a seizure, and by the time EMS arrives, they are post-ictal, they are agitated, and this is being seen as a threat to the patient or others, and they end up with a dose of IM ketamine, which in itself is not necessarily bad for their seizure disorder. The patient may suffer oral wounds. They can dislocate their shoulder. So one of the things I always do as part of a routine of an evaluation of a seizure patient is I check the shoulders, check the clavicles. We've had patients who have grand mal seizures and they have a shoulder dislocation that has to be reduced before they're discharged. They can also suffer other injuries as part of the fall. So we have to evaluate for trauma, whether they have a head injury, scalp injury, a laceration that requires repair, whether they have a fracture or evidence of fracture or injury to their extremities. Those are things that we all have to evaluate as part of our primary assessment in the field and as part of our assessment in the emergency department. If we're talking about a partial seizure, we're talking about an electrical disruption or short circuit within a portion of the brain, but not the entire brain, so that the patient's symptoms may depend on where this area of electrical disruption, or as I call it, a short circuit, occurs. So these are patients that typically have what we call a simple partial seizure. They may have rhythmic movements in just a portion of their body. It could be their right arm, their left arm, one of their legs, or their face. They may have sensory symptoms, which are tingling or weakness. They may make funny sounds. They may actually smell things. They may have a sensation of a funny odor that they can smell, but nobody else can. They may have an abnormal taste. They may have visual distortions, and they may have an upset stomach. They may also develop some psychiatric symptoms, again, depending on which portion of the brain is irritated with this abnormal focus of electricity. They could have the deja vu symptoms or hallucinations. They may become acutely anxious or fearful, and these simply last less than 1 minute. Some of these can actually progress to a generalized seizure. So there's something called a Jacksonian seizure, where the patient may start with a twitching in their hand, it goes up their arm, then eventually becomes a generalized seizure. But you have to think about that. When I think about some of these symptoms of simple partial seizures, I'm aware that these are possibilities, but it's usually not the first thing on my list in terms of what I'm looking for. So if the patient's all of a sudden fearful or anxious, or they're having hallucinations, I'm thinking more, is this patient having a psychiatric issue at play than having a seizure? Typically, these patients have been previously diagnosed, so family members or others are saying they're having symptoms consistent with previous simple partial seizures. If a patient says they've had 1,000 seizures a day, it's typically a partial seizure where they have these brief episodes, and it's not somebody having 1,000 grand mal tonic-clonic seizures a day. We also have a category which is complex partial seizure. To me, this is kind of a mix between a grand mal or a generalized seizure and a simple focal seizure. That's where the patient's having some focal symptoms, but they're also having alterations in their level of consciousness. So if you look back at the simple partial seizures, typically these patients are awake and aware. But if you look at a complex partial seizure, they may have an altered level of consciousness, and they may be confused, and they may also, though, be showing some localized symptoms such as picking behavior, chewing, mumbling. They may have emotional outbursts. So a patient having kind of a combination of alteration of level of consciousness with some focal symptoms. These can be very difficult. It can often be accused with drunkenness or drug use. They could be willfully belligerent or aggressive. And sometimes, again, we're not going to make that diagnosis. It may be more likely diagnosed by a physician, or by a neurologist. So either somebody else is going to finally make the diagnosis because we've passed them on to a neurologist, or the patient has a previous history and there's a family member or some medical record that indicates the patient has complex partial seizures, and here are the symptoms they typically have. If you have a patient with complex partial seizures, the family says this is what the patient usually exhibits as part of the complex partial seizure. You then have to talk with the patient and the family member about, should we treat you with a dose of benzodiazepine or not? It's often helpful to ask what helps these symptoms when they occur. I'd like to briefly talk about medicines you may come across. Here's a whole list of medications that we commonly see or may see in patients who have a history of seizure disorders. I've kind of tagged those that are more common for those of us who practice in the field or in the emergency department. So Depakote is a common medication. It's used for seizures. It's also used as a mood stabilizer for patients with manic depressive illness. It's generally a good medication. It has kind of a medium amount of side effects compared to some of the others, but you will see patients on it. Keppra right now is probably one of the most common medications that we see being used for seizures. It's available as an oral and an intravenous form, and its safety profile is pretty good. So it's one of the anti-seizure medications, anti-epileptics, with the fewest side effects. Lamictal is out there. You'll sometimes see it for other reasons, but Lamictal is out there as a seizure medication. Dilantin is kind of one of the older world medications for seizures. It's fairly cheap. It has some significant side effects, so patients with Dilantin can have sedation. They can have overgrowth of the gums, which can become unsightful. It can cause trouble with vision, and you have to worry about liver function. So Dilantin's a good seizure medication. It's very inexpensive, but it has significant side effects. Phenobarbital is an old world. It's a barbiturate. It has been used in the past for seizures. It tends to be sedating, and it just is not used as much as it used to be. Neurontin and Lyrica were both originally developed as anti-seizure medications, but now they're more commonly used for chronic pain management. Tegretol is an anti-seizure medication. We used to use it a lot 20, 30 years ago. It's not as commonly used now. It also has side effects such as sedation and abnormal or adverse effects on the liver. Trileptal and Topamax are also out there. They are in use in the community. You'll probably come across them. They're not as commonly used as Depakote, Keppra, and Dilantin, however. So those are all medications you may come across as part of your pre-hospital experience. Sometimes patients have a lesion, a focus of irritation of the brain that's amenable to surgery, so surgical treatment is an option. Typically, these patients have to be admitted to an epilepsy monitoring unit. They have to have pretty good localization of the seizure focus. In the more aggressive epilepsy centers, they will actually do a craniotomy, open up the skull, and place electrodes within the brain, and they can use those electrodes to specifically map the location of the seizures. And a neurosurgeon can do a resection of just the area of the brain that's causing the seizures, and they can do minimal amount of resection. So you may see that. So it is something that's out there, and it's really kind of end of the road, no other options available for patients. You may also see patients with a vagus nerve stimulator. It's an implant. It's typically in the chest, and it senses seizure activity, and if there is seizure activity, it stimulates the vagus nerve, and somehow it seems to stimulate the brain and overdrive the brain to abort the seizures. The vagal nerve stimulator can be affected by a taser, and it can be also activated sometimes by an external magnet. So sometimes the vagus nerve stimulator is in place. It's not set to auto fire, but if the patient has seizure-like activity, then either the patient or family member will put a magnet over the device and cause it to fire and hopefully suppress the seizure. We're seeing more and more placement of deep nerve stimulators to treat conditions such as Parkinson's disease and other chronic neurological conditions, but they're also being trialed in various locations as a way of treating refractory seizures. So it's another thing on the horizon that you may come across at some point. So patients with epilepsy may still have seizures due to other causes, or here are things that you should think about. So as I mentioned in one of the earlier comments, one of the most common reasons we see patients having seizures, particularly if they've previously been diagnosed with epilepsy, is they fail to take their medications correctly. So if they're supposed to be taking their Dilantin once a day or 3 times a day, depending on the dosing schedule, and they haven't done it for a week, well, they may have a breakthrough seizure. Sometimes patients, though, are still taking the right medication at the right dose, and they start having breakthrough seizures, at which point their neurologist or primary care provider may need to adjust their medication dose or add a second or sometimes even a third medication. There is a variation in medication effectiveness, so Depakote may not be the best medicine for all patients, whereas Keppra may be better medication for some patients versus others. So it's one of those things, it's almost like high blood pressure. We commonly start with medicines that work most of the time for most people, but sometimes we have to make changes in medication because the initial medication may not work right. One of the common causes of breakthrough seizures is sleep deprivation. So sleep deprivation, alcohol use can reduce or lower the seizure threshold. So what that means is sleep deprivation, alcohol use can make seizures more likely. So we advise our epilepsy patients that you have to get an adequate amount of sleep. If you're a college kid, you need to get your 7-8 hours in, regardless of what your study schedule requires. If you know you have seizure disorder, you should probably avoid alcohol, particularly drinking it in more than a moderate amount, because it can reduce your seizure threshold and make seizures more likely. Sometimes patients will have breakthrough seizures simply because they've had increased stress in their life or a new acute illness that can lower the seizure threshold as well. Dehydration and hypoglycemia can cause seizures to occur in a patient with epilepsy, as can hormonal fluctuations. So some patients can, particularly women, can have hormonal fluctuations, and their frequency of seizures can be associated with where they are in their menstrual cycle. And then sometimes flashing lights or other triggers can cause seizures. I don't think I have ever had a patient who's had a seizure associated with flashing lights. I know it's part of what they do when they do epilepsy monitoring and they do EEGs for evaluation of epilepsy. But it seems like I've seen it more often in movies than I've seen it in real life. But it can happen. So we have to realize that some epilepsy patients may never achieve effective seizure control and may experience varying degrees of financial, social, and legal problems. If a patient cannot work because they're having so many seizures that it's debilitating, then they may have financial issues. Having frequent seizures can interfere with a patient's social life. They may not be able to have a relationship with someone because they just have so many seizures that it becomes a disincentive for anyone to continue having a relationship. And then sometimes people can have legal issues because of these seizures. Let's talk a little bit about what you're going to do. So we've talked about patients having seizures. Our primary focus is patients having seizure. What do we need to do to take care of the patient and ensure their safety? So this is a lot of what you've already been doing. If we're talking about a generalized tonic-clonic or grand mal seizure, we have to always assure scene safety and provider safety. If trauma is not a consideration, we want to get the patient into the left lateral decubitus position if at all possible to protect the airway and avoid aspiration. We want to protect the head and limbs from injury, but we don't want to try to restrain the patient. We don't want to put anything in their mouth. We can hurt ourselves or the patient if we try to restrain them. Bite blocks are inappropriate. It's previous generations of EMS. We should not be doing it because the patient can break teeth. The provider can get hurt trying to put it in place. And then we can follow our ABCs and follow the protocol. So we need to maintain the airway. We need to suction as necessary. We need to provide supplemental oxygen. And we need to monitor for any cardiopulmonary problems that require intervention. We need to consider traumatic injury. We need to think about aspiration, particularly in a patient who has a seizure while swimming. And then we always need to think about hypoglycemia. So in the elderly and a pregnant patient or diabetic patient, we always need to check the glucose. I think for all of us, if patient's having seizure, we're going to do a finger stick anyway. And we also need to think about what are we going to do for seizures that last more than 5 minutes or that recur while under our care. And that would be a decision regarding whether or not this patient's in status epilepticus, which I'll discuss in a couple slides. Let's say the patient stops seizing, whether we treat them or not. Maybe they stopped before you got there. We're going to continue to monitor their cardiopulmonary status and their respiratory status. We're going to evaluate for injury. If there's evidence of shoulder dislocation or fracture, we're going to mobilize the affected body part based upon your training and skills. We're going to evaluate the patient's mental status on our arrival, and then we're going to re-verify their mental status while under our care. If they're confused when you got there and they're clear and fully oriented when you arrive in the emergency department, we need to know that. And it's important to document that. And then obtain a pertinent medical history and get emergency medical contact if that's at all possible. We also like you to talk to the witnesses. So, what happened? What did it look like? Do you have contact information on family members or friends who can provide additional history or can meet us at the hospital? And then what is the prior history? Is there a prior history that you're aware of seizure disorders or other medical problems? So, it may be a family member, it may be a coworker who has more information for you because the patient's not able to give that history. For the partial complex partial seizures and focal seizures, think about them if they may be acting like they're drunk or using drugs. You always have to think, is this a stroke or is this a stroke mimic or is it a diabetic reaction? What do we do if the patient's not acting right? So, was there a sudden loss of awareness? Were there autonomic or automatic repetitive movements such as picking at clothes, chewing, mumbling, or wandering around? Sometimes when these patients have these complex partial seizures, it's almost like when you have a child at home who sleepwalks at night, who kind of stands there and talks to you but makes no sense. And once this event is over, they don't remember it. So when you have patients with partial complex or complex partial seizures, talk calmly, try to keep the patient safe. Don't try to restrain them, which will only aggravate things. Prevent the patient from injuring themselves, and avoid violent behavior by minimizing patient contact. And if the patient is more comfortable with a bystander or a family member, make use of that. Let's say the patient is now post-ictal, seizure's over. So what are we going to do? We're going to monitor and check the patient's blood sugar. We're going to reorient the patient to their surroundings if they've had this complex partial seizure. We're going to look for injuries, and we're going to get more in-depth history. Again, we're going to get a description of the event from bystanders if we did not witness it ourselves, find out whether there's done any history, get possible or medical information, and follow up on patients' medications. Are there medications there available? You can see the pill bottles. Does the patient or family members say whether or not they're complying with their treatment plan? If you have a patient who's at a first sign seizure, they need to be transported because we need to figure out what the cause is, or if there's a reversible cause that represents an acute emergency. So think about that. We need to get these patients to the hospital. I really would discourage allowing the patient to refuse treatment because we don't know what's wrong with this patient. Have they had a head injury? Do they have a brain tumor? Have they had a brain bleed? Are they hyponatremic? Do they have some other infection going on that may have caused this problem? So think about that. How are we going to treat the patient? We're used to doing this. We tend to use intranasal midazolam. We can use intravenous midazolam if we have an IV in place. There are times when we get to the patient, they're post-ictal, we start an IV and then they have another seizure. If we have IV in place, we can use midazolam. So we have the protocols in place. The pediatric protocol is very similar to the adults. We check the fingerstick blood sugar. If the patient's hypoglycemic, we try to treat the hypoglycemia. We give them midazolam. And we use intranasal midazolam because it's quick. We can administer it quickly. So always remember to assess for associated injury in patients with seizures. So if the patient has had a fall, do they have a head injury? If they have significant head injury, there's a mechanism of injury in place. We need to have them at least in a cervical collar, things like that. Is there a dislocated shoulder? Is there a fracture somewhere that requires immobilization? Is there a wound that requires dressing or bleeding control? We use midazolam as our first-line drug for seizures. This is the dosing schedule. It's right out of the midazolam drug information sheet. We use intranasal midazolam. It has become the standard of care within Central Ohio that we use intranasal midazolam. If you have a problem with the MAD device, or if the patient will let you put the midazolam in their nose, then I would convert it to an intramuscular injection, and you can give them IM midazolam at the same dosing schedule if they will not allow you to use the MAD device. So if the patient's combative, you just can't get a good dose in, think about doing an IM dose, and I'll discuss the reasons for that in a moment. I want to talk about status epilepticus. So status epilepticus is a life-threatening event. Patients can have chronic sequela or even die from status epilepticus. If they're seizing so long that they have hypoxia or anoxia of the brain, then they are at risk for death or long-term disability, over and above what they may have had prior to the seizure. So what's the definition of status epilepticus? So typically, the definition of status epilepticus is a seizure that lasts more than 30 minutes, at which point the adverse events can occur. We typically call a seizure that lasts 5 to 30 minutes to be a prolonged seizure. Status epilepticus, like I said, is more a seizure that lasts 30 minutes or more, or a patient who has 2 or more seizures in a row without full recovery between seizures. So if a patient had a seizure, the seizure is gone by the time you arrive, but the patient is postictal, and then they have a second seizure or another seizure or a series of seizures without getting back to normal mental status. That is also considered status epilepticus and needs to be treated. Status, and I'll call it status rather than status epilepticus because it's easier to say. Status is really into 3 types. One is convulsive, which is what we're used to seeing. So the patient's having the grand mal seizure with tonic-clonic movements. It could be non-convulsive, where they're just spaced out, or it could be partial seizures where they're having these focal motor seizures or focal sensory seizures not associated with altered LOC. I'm not sure how many of us would recognize non-convulsive seizures. Typically, the patient's on an EEG monitor and they see seizure-like activity, but the patient's not convulsing. So it would be very difficult for us to determine, at least as a new diagnosis. Partial seizures, again, they're having the focal motor event that's lasting more than 30 minutes. Typically, partial seizures that are in status do not have airway issues and they're not hypoxic. Most treatment algorithms for status epilepticus say that we treat the patient for status if their seizure is lasting for more than 5 minutes. And we do that because by the time we arrive, they've already been in the seizure, and we want to stop the seizure before they get into the 30-minute interval. So just because they've been having a seizure for 10 minutes doesn't mean we're going to wait for another 20 minutes to treat this patient for status. So if the patient's having a seizure for 5 minutes or more, we're going to treat that patient. I expect that if the patient had a seizure, EMS is called, they had been having a seizure for 5 minutes or more before you arrive. So what are we going to do? So if the patient's still having a seizure on your arrival, consider them in status. If the patient is postictal and has another seizure, the patient is in status. We're going to give them oxygen. We're going to check their finger stick. We're going to give them D10 if indicated, and we're going to treat them with Versed as per the previous algorithm. So the treatment is Versed, and we're going to stop that seizure. So what happens if we've maxed out on midazolam? We've given them 10 milligrams intranasal or IM. We've got an IV in place. They have a seizure, and we give them more midazolam, and they're still seizing. What are we going to do? What medicine might we have available currently in our drug bag that we could use, and we don't have to add another drug? Well, if I was in the emergency department, I typically would, if the patient's having status, I'm going to give them max out on benzo. I'm going to consider giving them either IV Keppra or IV Dilantin. And another drug I'm going to consider is to give the patient propofol, which is a general anesthetic. If I give them propofol, it's going to stop the seizure, and I'm probably going to have to intubate the patient and put them on a vent. Well, what drug do we have that's not propofol, but we use for intubation? Well, ketamine. Ketamine is now recognized as being a potential drug to treat status epilepticus. We can give the patient 1 milligram per kilogram. Some studies say up to 1.5 milligrams per kilogram IV push, and we can then put them on a ketamine infusion at the hospital at 1 milligram per kilogram per hour. So we are considering for 2020 using ketamine as a second-line drug for true status epilepticus. You have maxed out on the benzodiazepine, and the patient's still having seizures. Well, let's give them ketamine. You need to anticipate that we may need to put an airway in. So if you're going to give them ketamine at 1 milligram per kilogram, you've already given a generous amount of benzodiazepine. There's a high likelihood that once you get the ketamine in, you're going to have to secure the airway. So be prepared. What happens before 2020? Well, if you truly have a patient in status, call me. Call me on the medical control line. I'll authorize the drug. At this point in time, I'm not authorizing ketamine to be used as a routine for status. I'm saying that if you have maxed out your meds and the patient's still seizing and you've got a reasonable transport time, call me on the medical control line and we'll give the patient ketamine. So I'm going to talk to the EMS coordinators and the chiefs in September. After talking with the protocol committee, I think we should consider adding an indication for ketamine for status epilepticus. So ketamine for us, I think, has become the wonder drug, and we're just finding another reason to use it. The last slide I have is to talk about lorazepam or Ativan versus Versed or midazolam. Periodically, I get a note from one of our providers that says, hey, I think we need to use lorazepam or put Ativan back on the truck because sometimes Versed doesn't work. We've given them maxed out Versed and it doesn't work, or the patient stops breathing and we have to secure the airway. So why don't we have a lorazepam on the truck? Well, I think we have to talk about that a little bit. You know, I did a literature search. There is no head-to-head study of IV lorazepam versus IV midazolam. There are some out there that have looked at lorazepam versus Valium, and basically there's no difference for intravenous administration. One of the best studies in terms of EMS treatment of seizures is the Rampart study that came out of the University of Michigan in 2012. It was published in the New England Journal of Medicine, and they compared intramuscular midazolam versus IV lorazepam. And they found that, so basically the patient got IM midazolam 10 milligrams as soon as the EMS arrived versus 2 to 4 milligrams of IV lorazepam once an IV was secured. And it was a very good study. It was well controlled. It was prospective. I mean, it was a well done study. And in the end, they had over 800 patients split 50-50 between the two arms of the study. 73% of the patients treated with IM midazolam stopped seizing before arriving in the emergency department, and 63% of the patients who received IV Ativan lorazepam stopped seizing. So intramuscular midazolam was more effective in stopping seizures than IV lorazepam. If you look at the midazolam group, seizures stopped 2 minutes faster with midazolam, and that's mostly because of the time it took to get the IV started. Once the patient got patients got IM midazolam within a minute and a half of EMS arrival, it usually took about almost 5 minutes to get the dose of lorazepam in, and the seizures stopped 2 minutes faster, although it took longer for seizure to stop after the administration of medicine intramuscularly versus IV. So IV worked faster after the drug was in, but it just took longer to stop the seizure because it took longer to get the IV in. There was no difference in intubation rates and no difference in recurrence of seizures. So this study suggests that midazolam, at least as an intramuscular drug, did better for the patients versus IV lorazepam. From my perspective, if we've given them patients max dose of either lorazepam or midazolam and they're still seizing, then it doesn't mean we gave them the wrong drug. It means the patient needs a different drug. And if we had to give them so much of a medication to stop the seizure that we had to manage the airway, well, that's kind of a side effect of medication administration. So I'm not trying to minimize others' concerns. I just think that there's no reason for us to make a change from midazolam to lorazepam, particularly if we're going to go to ketamine as a backup drug. So that's all I have. Hopefully it's been helpful. More to come regarding what we do with ketamine. Again, if you have a patient who's truly in status, you've maxed out the doses of benzo that you can give the patient, meaning maxed out on midazolam, call me and we'll discuss whether or not the patient should get intravenous ketamine. So thanks again. Post any questions on Workplace.